So we have 7 wonderful presenters and presentations today. I'm delighted to welcome all of them to this session. I will introduce them quickly, and then after that they will go and present one by one. So Leah Neo is an assistant in research at the University of Michigan. Leah will go first. After Leah, we'll have Dr. Maryann Mason, Associate Professor of Emergency Medicine at Northwestern University School of Medicine. Then we'll have Dr. Kiesha Fraser, a pediatric emergency physician and the Director of Emergency Department Physician Outreach for Children's Healthcare of Atlanta. Susan Parker, who is a doctoral candidate with the University of Michigan School of Public Health, will go next. After Susan, Dr. Karen Liller, Professor and Director of the Activist Lab with the University of South Florida College of Public Health, will present. After Dr. Liller, we will have Dr. Stephanie Bonne, who is an Associate Professor of Surgery and the Trauma Medical Director with the Rutgers, New Jersey Medical School. And finally, we'll have Dr. Nicole Kravitz Wertz, Assistant Professor in the Department of Emergency Medicine at the University of California, Davis. So with that, delighted to have you all here with us, close to 60 participants today, which is wonderful. And we'll begin the sharing of the screen, and the presentations will start with Leah as the first presenter.
All right. Hello, everyone. It's nice to be here. Again, my name is Leah New. I'm a junior at University of Michigan, majoring in art and design. I will be presenting our research today, and Jane Profit is in the audience. Next slide, please. For our research, we focused on a bit of a literature review, but of creative practitioners. So instead of looking at papers for review, we looked at artworks by artists and designers. We looked at a total of 39 art and design works to find patterns in them and to form a typology of firearm injury prevention. Next slide, please. So for our results, we felt that these works could be put into 4 broad categories. What's different about our approach is that we weren't grouping them by painting, sculpture, or performance. We were grouping them differently so we might find these different mediums across the categories. So social commentary, the artist's work makes a statement, maybe with or without a community in mind. It can be used to invoke a sense of justice or trigger a strong emotion in the viewer. For social engagement, the key is that it works with a community in mind. The artists involved often want to inform viewers through the work in hopes of them engaging with the community and that particular social issue. For collaborative work, it's more of a method in art making. Across the categories, 1/4 of the works were collaborative, and we thought this was significant because not many works by artists in general are collaborative. This is to also point out that there are the same amount of collaborative works as there are social engagement works, and I believe this is because community is vital to social engagement. So these types of works are almost always collaborative, and with this in mind, there are a total of 6 works that were both collaborative and socially engaged. And for design, we expected to find more of this genre of work, and this is why we added it as a category. The fact that our topic is related to a design product, we expected to find more creatives working through these problems through iterations of the product itself or through speculative design. Next slide, please. For the implications of our research, we expected to find more designed objects, in which case design would have been included amongst the 3 other categories rather than a category of its own. However, there were so few examples of designed objects that we wanted to draw attention to them in its own category. There wasn't even much speculative design. Speculative design is when designers create something that isn't meant to be mass produced, but is used to get people to speculate about how to solve a problem or develop new ideas. From reading the text associated with the works, small amounts of funding can have catalyzing effects. Things like events, reports, and community engagement can be important to seeing the lasting effects of the work. Unfortunately, though, the relative lack of analysis across the whole field can stent the discussion around the work, so adding social scientists to the mix can help to spur on this discussion. Thank you.
Thank you very much, Leah. And of course, during the Q&A, if there are any questions, we'll get back to you for sure. Next, we're going to have Dr. Mason.
Hi, good afternoon, everyone. I'd like to thank the FACS team for making this remote symposium possible. I attended last year, and it was one of my favorite events of the year. So I'm happy I can be here, but not be here. So my talk today is about regional variation and race, ethnicity, and age variation in unintentional firearm deaths among 0 to 24-year-olds. And this all takes place in Illinois. So it's an Illinois specific study. Next slide, please. This is over an 11-year period. We wanted to look at the regional and demographic distribution of these unintentional firearm deaths. And even though our title says 0 to 24, we wanted to push it out 15 to 24 to be more adolescent focused. So we used Illinois death certificate data, and we included people who were less than 25 years old, lived or died in Illinois, and had an ICD code of unintentional firearm death. And then we just did descriptive procedures to look at differences by age group, urbanicity, and region, and then race and ethnicity. Next slide, please. So what we found was there was a total of 53 decedents over the 11-year period. There was a wide age range, but the median age was 16, so mid-adolescence. And then there was a solid cluster at 20 to 24 years old. Mostly a male problem, 90% male. Interestingly, these deaths overwhelmingly occurred on a weekend time period, so a Friday, Saturday, or Sunday. They're almost evenly split between non-Hispanic white and non-Hispanic blacks, with a very small portion of Hispanics. These deaths happen in a small subset of Illinois' 102 counties, so only 28% of counties had one of these deaths. There was regional variation between north, central, and south, and there was urbanicity variation between urban, suburban, and rural. So we found that Black decedents were more likely to be on the older age range, 20 to 24, and that white decedents were more likely to be rural. Next slide, please. So all of this tells us that a targeted prevention approach may be useful because not all places experience this problem the same way, and not all populations have the same experience. So we think tailored messaging is a great approach to address this. And we think there's a need for more in-depth data about the firearms used, where they locked, where they stored, who owned them. And so I just want to put a plug in for the National Violent Death Reporting System as a possible source to extend these data. Thank you.
Wonderful. Thank you for that great presentation. So next, we're going to have Dr. Kiesha Fraser.
Hello, thank you for inviting me. So I would like to thank my collaborators and co-authors at Emory plus Children's Healthcare of Atlanta and those who assisted in extracting this data. The title of my study was a 5-year comparison of pediatric motor vehicle and firearm injury trends in the US. Next. So our research question was, what comparisons can be noted between the two most common causes of death in children, motor vehicle and firearm injury over a 5-year period? Our team retrospectively extracted data from a FIS billing database used by children's hospitals throughout the US. We included hospitals who reported completed data during the time frame and included diagnosis codes for occupant motor vehicle injury and ballistic firearm injury. Analysis was done via linear regression. Next. So the results that we found, you'll see that there's two different displays. Off to the left, you'll see that we compare the 5-year trends of firearm injury to motor vehicle injuries for different hospital dispositions. Looking specifically at the inpatient admission, you'll notice that there was a change over the 5-year period for a 15% increase in inpatient admission for firearm injury, whereas a minimal change for motor vehicle injury. When you look at ICU admissions, you'll note that there was a 13% increase in firearm injury ICU admissions versus a decrease of 5% for motor vehicle injury. When you look at death or mortality, you note that there was a 21% increase in death over the 5-year period, where there was a 1% increase for motor vehicle injury. One thing also to note is the numbers at the very top that show you the amount of cases of firearm and motor vehicle injury. If you look at the table on graph to the right, this basically just shows the 5-year trend. Looking at the US Census regions, you'll notice that there's an increase in the South, in Midwest for firearm injury, whereas motor vehicle remains steadier but higher in the South area. Next slide. So the implications are notable. Next, the implications are notable because these trends demonstrate increasing pediatric morbidity and mortality attributed to firearm injury, whereas motor vehicle injury remains stable. Motor vehicles are highly regulated in design and use and include many passive safety features. In contrast, firearms are much less regulated and studied, and safety designs are less frequently mandated. These regional implications may indicate prevention strategies in place, such as child access or safe storage laws or ERPOs. Thank you so much.
Thank you very much. I also, before Susan starts, I would say a reminder for participants, please feel free to type in your questions for any of the presenters if you have in the Q&A box. Thank you.
Thanks so much to FACS. Thank you so much, Dr. Rawani, for organizing, as well as to the Rackham Predoctoral Graduate Research Fund, IHPI at the University of Michigan, and Arnold Ventures for funding some of this research as part of a broader non-fatal firearm injury project. Next slide. So my research question is, can hospital data accurately capture non-fatal firearm injury volume and intent? And this question is important for a few reasons. First, as we've discussed throughout this, non-fatal firearm injury is much more prevalent than fatal firearm injury, yet we do not comprehensively track it. And we instead tend to rely on proxies like homicide or crime. And second, we know that the majority of gun injuries are actually seen in emergency rooms. And so emergency room data could be a very valuable way of capturing what we're seeking to capture, which is non-fatal firearm injury. This is also important because recently the probability sample of non-fatal gun injury that we've relied upon for many years proved to be inaccurate. And so some of these inaccurate estimates falsely suggested that a national increase in gun injury was happening. The source for these inaccurate estimates was the National Electronic Injury Surveillance System. And so researchers and journalists have thought about replacing this with NEDS, the National Emergency Department Sample. And this sounds good, right? Like bigger probability sample, this is going to maybe fix some of our problems. But as I'll show you, there are potentially some strengths to replacing NEDS, but we see some discrepancies in terms of injury intent that are really important to further evaluate. Next slide. Okay, so what you're looking at is from 2006 to 2014, the national estimates of non-fatal firearm injury generated by NEDS and generated by NICE. And so the point estimates, as you can see, hover from about 75 to 80,000. The giant green kind of caterpillar looking view is NICE because it has such a small hospital probability sample. So this looks good, right? Next slide. However, when we look at some of the injury intents, we start to see some distributional differences that are important to learn more about because they have vast influence about how we invest our policies and what kind of prevention we're interested in. It seems as though unintentional injury may be overstated in NEDS, where assault may in fact be underestimated in NEDS. This is because NICE heavily invests in medical coders who document the conditions around the emergency department event. So right now we don't know if particular states, hospitals, or laws or time periods drive these distributional differences. Thank you.
Thank you very much, Susan. Next, Dr. Liller.
Yes, thank you. It's a pleasure to be here to talk about our study on firearm morbidity and mortality among youth in Florida for years 2006 to 2018. I am Dr. Liller, and I'd like to acknowledge and thank my co-authors, Drs. Etienne Proct, Abraham Salinas, and Nicholas Thomas from the USF College of Public Health, and Dr. Edelyn Verona from the USF College of Arts and Sciences. Next slide, please. So the background is that, as we know, Florida suffers from high rates of lethal and non-lethal firearm injuries, yet comprehensive data on firearm injuries and deaths among adolescents are lacking. So our research question was, what is the extent of these firearm injuries and deaths following ED or emergency department and hospital arrivals among 10 to 19-year-old adolescents in the state for those years? What are the socio-demographic characteristics? And what are the health costs associated with these injuries and deaths among adolescents in Florida? For our research methods, we did a descriptive analysis of data from the Florida AHCA, or Agency for Healthcare Administration, ED visits and inpatient episodes. We calculated the total number of injuries and deaths and socio-demographic characteristics. We calculated direct medical costs, and this was done by the specific cost by charge ratios. And we looked at insurance status because we see this as a proxy of burden among public and private sectors. Next slide, please. So what did we find? Well, the overall data showed that there were 18,000 firearm-related episodes from 2006 to 2018, most of them being in the emergency department at 72%, and this indicated an annual average in excess of 1,000 injuries among our group. Over 700 individuals died of their injuries after coming to the hospital. So when we looked at demographics, we see that our group was largely male, they were Black, they resided in a metropolitan area, a major area, and their median age was 17. As for the health cost, well, Medicaid was the primary payer for over half, 52%, 20% uninsured. The total patient care costs was $180 million, and firearm injuries claimed over 35,000 inpatient bed days. Next slide, please. So our implications are, looking at these injuries and deaths using this methodology has not been previously done, but we did show that there's an excess economic and healthcare burden of firearm injuries in poor and young African-American males in Florida. And in the future, we hope to incorporate geocoding and risk factor modeling, along with targeting our interventions and policies on the most costliest events, the regions they occur in, and of course, we need to address equity issues. Thank you very much.
Thank you very much for that presentation. Next, we're going to hear from Dr. Stephanie Bonne.
Hey, so thank you to FACS for the opportunity to present this work. This is looking at the accuracy of the external cause codes. I think we had a really interesting presentation just now from Susan about using NEIS and NEDS, and this is sort of getting at the heart of that, which is essentially with these hospital data sets, garbage in is garbage out. So next slide, please. So as we saw, there's not really a accurate way to quantify non-fatal firearm injury in the United States right now. Public health data sets that we use rely upon the quality of external cause codes. So for example, I'm a trauma surgeon. If I operate on someone and take out their spleen, I write that I did a splenectomy. But the reason why they needed a splenectomy, if they fell off a ladder, if they were in a car accident, or they were shot, is optional to add to the external cause code. We know that the CDC estimates are becoming increasingly unreliable, and external cause codes for firearm injury are specifically usually report the mechanism, the intent, and something circumstantial about it. So for example, it would be like assault by a handgun injury or unintentional self-inflicted rifle injury. So we reviewed all of our gunshot wound injuries for 2017 at our single urban trauma center in Newark. We reviewed the trauma history and physical, the emergency medicine history and physical, the social work notes, and the discharge summaries for evidence that was mentioned in the narratives about the perpetrator, the weapon, and the intent of the injury. One person abstracted all that data from the chart, and then we had two independent coders assign what would be the code based on that information in the chart. And then we looked at what they actually were coded for. And Kappa statistic was used to assess the difference. Next slide. So we had 376 gunshot wounds in 2017 at our center. 53 of them were completely absent of all E-codes and therefore not in any data set at all. There was agreement about 57% between the billing data and what we were able to abstract from the medical chart. There was an 85% agreement in general assaults, and a 32% agreement in the undetermined or unintentional category. 100% agreement in rare intent categories, for example, suicide attempt by air gun. Weapon E-codes were reported in only 21% of the cases. And then place of occurrence, which is the Y codes, were present for 312 of 323, but 215 were non-specific, like street or field. There were no perpetrator E-codes other than the 3 incidents of self-harm. We found a lot of overuse of assault codes as well. Next slide, please. So in summary, at a single center, we found that 14% of the patients were not reported at all, which is consistent with our known underreporting of firearm injury. And we found a 67% accuracy rate, basically. We are currently transitioning this to a multi-center trial. If you want to participate, please contact me with your email.
Thank you very much. And last, but definitely not least, Dr. Nicole Kravitz.
Thanks, Ollie, and thanks, FACS, for having me. Hi, everyone. I'm Nicole Kravitz-Wertz, and I'm an assistant professor with the Violence Prevention Research Program at the University of California, Davis. And so today I'm pleased to share some preliminary work, which is in collaboration with my co-authors and UCD Hospital-Based Violence Intervention Program team members listed here. Next slide, please. So there's a robust body of research on sociodemographic disparities linked to systemic inequities in pre-hospital determinants of violence and in post-discharge outcomes following violent injury. However, less is known about differences in in-hospital care and treatment received by violently injured trauma patients, particularly youth. In this study, therefore, our objective was to compare differences in the likelihood of admission to the adult versus pediatric ICU among violently injured versus non-violently injured pediatric patients 13 to 17 years of age. Using data from the Institutional Trauma Registry for a single high volume level 1 adult and pediatric trauma center in California for the period January 2005 to February 2020, we categorized injury mechanism based on ICD-9 and 10 E-codes and defined violent cause to include gunshot wounds, stab wounds, and blunt assaults, and non-violent cause to include motor vehicle crashes, falls, and cyclist or pedestrian collisions or accidents. And motor vehicle crash injuries served as our reference group for comparisons. Among 13 to 17-year-old pediatric patients who were admitted to the ICU after traumatic injury, we fit standard bivariate and logistic regression models to examine the association between violent versus non-violent injury mechanism and adult versus pediatric ICU admission. Next slide, please. So a total of 1,356 adolescents 13 to 17 years of age were admitted to ICU care with traumatic injuries. Roughly 1/3 of those were admitted to the adult ICU. In bivariate analyses, we found that youth admitted to the adult ICU were significantly more likely to be older, male, Black or Latinx, to have public insurance, and to have a higher injury severity score, or ISS. In the main analyses controlling for these sociodemographic characteristics in ISS, we found that pediatric patients with gunshot and stab wounds had 4.4 and 3.3 times the odds, respectively, of admission to the adult versus pediatric ICU compared with those admitted for motor vehicle crash injuries. And no other significant differences by injury mechanism were observed. Next slide, please. So although these findings are still preliminary and based on just a single site, we doubt that they're unique. We think they suggest that violently injured pediatric patients may be subject to stereotypes and implicit biases about age and dangerousness, including the so-called adultification of Black youth and youth of color, and the socially constructed, often racialized tendency to equate violent injury, particularly violent injury involving a weapon, with personal shortcomings, criminality, and blame. And moreover, just in closing, we think that these may therefore have important implications for the care and treatment received by violently injured young people. Thanks so much.
Thank you very much. So this was really impressive. We had 7 presentations. I know how hard it is to present all these materials so clearly in just 3 minutes, and you all did an amazing job. So we have about 10 minutes or so left for some Q&A, and there are some questions that have already been posted on Q&A. I see that a couple of them are being real-time answered. The conversations with Dr. Stephanie Bonne about the codes, whether it's trauma registry or billing data. But let me start the Q&A session with a question for Dr. Liller, which is, Dr. Liller, they're asking to clarify, was your data set for the entire state of Florida or a coalition of hospitals? And you're on mute.
For the entire state of Florida.
Okay, wonderful. Thank you very much. Another question just came in, which is for Leah. How did you go about finding and determining what artwork you included in your review, and what other possibilities do you see for the important collaboration between the arts and firearm injury prevention research and anything else that your team is looking forward to doing this innovative work?
So for finding the artworks, we basically went on a huge Google search, and just kind of using the keywords of firearm injury prevention, like firearm artwork, firearm and design. And basically for determining the artworks that we want to include, we kind of wanted to include a little bit of everything from paintings, from exhibitions, from design works, and just trying to get an overall sense of what artists and designers were generally doing in this field. And for the other possibilities for a collaboration, let's see. I think for something that we would like to do next is to try to see how artists are paired with social scientists. So, when we were researching these works, there weren't a lot of area for people that were discussing these works beyond them. Sorry, my noise is cutting out for a second. So that we didn't have a lot of documentation of people really discussing the works or kind of giving feedback on what the works were about or how they were serving the community. So I think by including these social scientists with it or trying to seek out works that are doing this type of collaboration, I think we can try to like track these works from beyond them.
Yeah, I think that's fascinating, and congratulations on this innovative work. Not many people, I think, to my knowledge, have worked on this area, so it's really wide open and really wonderful work. Of course. So let me ask a question. Dr. Mason, you presented results, and please correct me if I'm understanding is not correct, but you presented some really interesting results about regional differences within the state. And so the question is, what are some of the possible implications of what you found? What are some of the ideologies or causes behind this between region variations within the same state, and what policy solutions do you recommend or come to mind?
Yeah, I don't know that we got into that with our research, but having a very thorough understanding of Illinois' regions, north, central, and southern, I do think that we understand that the presence of firearms in rural counties and actual Second Amendment sanctuary counties in Southern Illinois may play a role in firearm access in that group. And then the Northern Illinois was primarily African-American youth 20 to 24 years old. And I think that's a very different way of accessing firearms in terms of that population. Just looking at our homicide data, we know that that is a very overrepresented population in homicides. So the sense I get extrapolating from that is that access to firearms may come in a very different way for that group. And so the implications of that are messaging campaigns have different ways to communicate about firearm safety and access, and there may be links to, there may be more similarity between homicide and unintentional firearm death in Northern Illinois than in Southern Illinois. So making those distinctions and how we try to prevent those will be important.
Yeah, really good point. I can't help but think about, things that are the lever is at the state level, let's say, policies. And, the point that you raised about tailoring some of these interventions. And so how, a particular state policy firearm or not firearm may pan out, may exert its effect in different regions or counties of the same state. That's fascinating to look at. Thank you very much.
Thank you.
So I think there are some conversations with Leah in the Q&A, but let me go to Dr. Kiesha Fraser Doe. So you presented those results very clearly and really interesting trends that you observed. What do you think those trends show us about pediatric firearm injury in the US as a whole? What is the next step from your perspective? What kind of things we can do as the next step beyond your project?
So I think largely the reason why I compare them is that as an injury prevention researcher in general, I've noticed, and working in the emergency department, I've noticed improvements in decrease in fatality and injury and motor vehicle injury in general. And so looking at some of the modalities that were used in a public health manner to reduce motor vehicle injuries, kind of trying to transpose as much as possible, because of course there's different political and cultural implications, but using some of those same public health approaches to actually impose or make change or impact change for pediatric firearm injuries. So as people have mentioned before about child access laws and ERPOs and things like that, that actually might actually may actually reduce the amount of pediatric firearm injuries. Those are, I think, the implications of my research, kind of using, and then specifically looking at the different regional. So if you look specifically at the fact that in the South, there's larger volumes of pediatric firearm injury and also motor vehicle injury, and looking to see what are the differences between the southern US census regions and the other areas and what changes were made. Because if you notice, there was graphs where actually firearm injuries were decreasing in certain regions. What differences did they make in comparing those different regions?
Absolutely, absolutely, well said. Yeah, thank you, makes a lot of sense. Thank you very much. Susan, can I go to your next? I mean, what an interesting presentations, those disparities about needs and nets, and especially as it comes to intent. So one question that's sort of urgent comes to mind as firearm researchers is, what should we do now? What are your thoughts about researchers who are studying non-fatal firearm injury, especially if they're interested in determining intent? What data set to use and what to do? Any thoughts or ideas?
So to my mind, and so one thing we're gathering is some of the state level data, because it's unclear if there are states that are driving some of these trends. It could be the case that maybe, Michigan is coding all of these improperly, and that's the distribution we're seeing. Who knows? I do think, though, we need to rely a bit more on police data, because that should give us something of an estimate, or at least like a lower bound. If we think that people feel uncomfortable reporting to police, that might give us a lower bound in the number of assaults we should expect to see in the hospital data. That might be a little bit more comprehensive for other injuries we care about. But I do think that this underlines proceeding with some caution about unintentional firearm injury for now until we know more.
Thank you.
So I'll jump in and say, I think there's a couple of really good advocacy opportunities here. I mean, I think we need to be advocating for better data. The National Violent Death Reporting System is an extraordinarily rich data set on violent death because it uses, there's a big difference between administrative data and registry inputted data. And I think if we really want to find out what's happening in any sort of level of detail about non-fatal firearm injury, we need a registry. So there are statewide, you can advocate for your state that the health department or somebody creates a registrar. The other thing I will just put in a tiny plug that the American College of Surgeons is launching a project right now through their Committee on Trauma, enrolling centers that are participants in the Trauma Quality Improvement Project, to essentially take their TQIP data and add about 20 data fields for all non-fatal firearm injury patients, which is going to be a national study, which it'll be a sample, but it will be probably the most robust study out there. So if you are close to or know somebody at a TQIP center, find out if they're participating, because you'll have access to that data as long as your center is participating.
Thank you, Dr. Bonne. Yeah, that's a really good point. That's the NCGVR, National Collaborative on Gun Violence Research funded project. And those projects are all listed on NCGVR website. If you haven't seen it, please take a look. Dr. Matt Miller of Northeastern University and Harvard also has a project recently funded in CGVR looking at the quality of these ICD codes as it relates especially to intent. So I encourage you to take a look at it as well. I think we still have maybe 2 or 3 minutes left. And Dr. Bonne, thank you for that comment. So let me actually go to Dr. Kravitz, Wertz, and ask a sort of philosophical foundational question, which is this sort of thought-provoking results that you presented. What are their implications for HVIPs, hospital-based violence intervention programs? Should we focus on specific subpopulations? This should be universal. What are your thoughts about that?
Yeah, thanks. So this work was actually inspired by our violence intervention workers who are part of our hospital-based violence intervention program. They were noticing that a lot of the adolescent patients that they were going to visit were ending up in the adult ICU. And while our work doesn't sort of get at the underlying reasons for why that's happening, we do think that there may be some real implications for then how our intervention workers interact with these violently injured young people in age-appropriate, developmentally appropriate ways. Lots of times the adult ICU don't have the same level of trained staff. They don't necessarily have child life specialists. And I think it's important to remember that these are still, really young, oftentimes kids, and that, hospitals, they've just experienced, a trauma, and hospitals, there's a lot of sort of institutional distrust grounded in, large histories of disenfranchisement and marginalization. And so I think it's, these results just really underscore, I think, how we need to really think critically and intentionally about how we care for violently injured young people in the hospital, and HVIPs have, I think, a real important role to play in that.
Agreed. Thank you very much, Nicole. So we are at the end of the session. There is one question from my good colleague, Karen Brownson of King County for Dr. Mason, which I think I'll let them maybe take that question offline and answer that. But I would like to thank everyone for participating in this session.